Okay, this first one, I immediately just saw it, and so I read the question. I said, serum electrophoresis is most likely to show which of the following patterns. And I was really unfamiliar with this. I just know I didn't know like I've never really seen graphs on this besides in multiple myeloma. And so I was just like, well, I didn't really know what to go off from based off this in any way. And so I read the question, and I mean, so the highlighting is weird in this, but I didn't.
Yeah, don't worry about the highlighting. It's always off when you review these. So
Yeah, and so I remember just reading like, okay, he's a sick kid. He has some hip pain, and then blood cultures grew Staph aureus, and I really had no idea of what to go off from here, and so I just made a complete yes, and I was unfortunately wrong. I had no idea.
okay, did you get the diagnosis by any chance?
Um, I don't think I did. Is this just hip pain with is it just like septic arthritis or something like that?
Well, it is septic arthritis, but he also gets pneumonias. He also gets, staph, right? Is it normal for a 12-year?
Oh, no, it was a gamma globulinemia.
Exactly. So if you got that, then right, you would have picked D. You get what I'm saying? The curve, there
Yes,
is
because
no
there's no gamma globulin in that picture. Yes.
exactly. So key here, I think here is I think you didn't make the jump for the diagnosis because I think if you got the diagnosis, you probably could infer or imply that they're talking about D. You get what I'm trying to say?
Yes.
So agon, I can never say it, but yeah, Bruton's anemia, right?
Yes.
So yeah, so boy, right? Anytime you get a boy that has a bunch of infections, right, in a pediatric population, you got to be thinking about some kind of immunodeficiency. So especially with a boy, right, Bruton's, right, immunodeficiency. So that has lack of gamma globulins, right?
Mm-hmm. Mm-hmm.
Okay, this one here.
Um, so I remember reading the questions. I felt confident going into this. Um, I don't remember the question. So which of the following acute disorders is most likely cause acute renal failure? Um, okay, I remember reading the answers, and I remember just thinking, so dark red urine becomes oliguric in urinalysis. I remember thinking that urinalysis is positive for blood. And I was thinking, like, okay, and I thought that was some way of saying that he has red blood cell casts.
Okay.
Um, and I thought that was just that's so I went straight off that.
Okay.
I remember thinking like I really don't know because and they're talking about like I believe it's a superficial perennial like injury, the dorsal space between the first and second toes.
Okay.
And so I was like, I really don't know this, and I thought that that was the way of them saying that this is red blood cell casts. And I remember that it was between interstitial nephritis and glomerulonephritis, and so that's why I have those two unmarked. And I was like, I really don't know between them. I'm gonna go with interstitial nephritis, and it was just not that. Um,
Yeah, so key thing here when you read this, okay? So I'm gonna work you through kind of how I think through this,
yeah.
okay? And then let's compare contrast, right? So I'm gonna say which of the following acute disorders is most likely cause of renal failure, so you know it's a kidney problem. You read through these, right? In your mind, I'm already thinking this is going to be a huge risk factor, like a risk factor question. Does it make sense?
Mm-hmm.
Because you have all these nephritises, right, and renal issues into one setting, right? So you have glomerulonephritis, inflammation, right, hemolytic uremic syndrome, right, which you can see in like E. coli infections, things like that. Interstitial nephritis, right. In my mind, the risk factors for those are going to be like NSAIDs or drugs. Nephrotic syndrome, you're going to pee out a lot of
Protein, yeah.
protein, right? And depending on kind of what age range, right? You have minimal change, you have membranous, things like that, right? Tubular necrosis, right? That means that acute tubular necrosis or ATN, right? That means that the kidney is getting struck like acutely and dying, right? And sloughing off. Usually either due to big trauma, bleeding,
Yeah, it's an
hypotension,
acute kidney
right?
injury.
Dehydration, right?
Yeah.
So an acute kind of lack of blood supply that causes the kidney to die. So these are the things I'm thinking about when I'm thinking about these answer choices. And then I'm going to read 42-year-old male struck by a motor vehicle accident. So this is an acute issue. Injury to the tibia, right? Neurovascular is okay. 24 hours, he has leg pain, paresthesia between the first, second toes that goes with his, fracture, right? Patient begins to pass dark red urine, becomes oliguric, right? So kidneys are injured in a sense of probably hypotensive, right? Because sloughing off and peeing out blood, urine analysis is positive for blood, but no erythrocytes are seen on macro examination. So, either CAS or something like that, right? They're kind of a little bit ambiguous with that. So, which of the following acute disorders is most likely to cause a renal failure? Glomerulonephritis, right? Inflammation of the glomeruli, right? I don't have any kind of risk factors for that, right? I just have
When you
trauma.
see glomerulonephritis, you're thinking again like any type of like nephritis, you're gonna have like almost like a sickness, right? Like fever and like something that
Sure.
it indicates like an infection.
Yeah, some kind of infection. I would say inflammation of the nephrons, right? And a lot of things can cause glomerulonephritis, right? I mean, post-strep glomerulonephritis, right? That just you have a
Mm,
infection, and then all of a sudden your immune body causes inflammation, right? But also, various drugs, things like that, can cause glomerulonephritis, right? So some inciting event that causes inflammation of kind of your glomeruli, but it just doesn't fit here, right?
yeah.
Um, Hemolytic uric syndrome, right? That goes with E. coli. I don't see an infection of E. coli. Interstitial nephritis. Remember, these are drugs like NSAIDs, right? Mainly,
Inside, yeah.
right? Usually NSAIDs, antibiotics, sometimes diuretic can cause it. And remember, what are you going to see, right? You're going to see eosinophils, right? It's more of
Exactly.
a
And that's what I'm saying. So that's what's like frustrating is like if I knew when I was taking this exam, I was thinking, I really wish they said something about eosinophils with this, but I don't see that here. I hate that, but I don't think it could be anything else. And so I knew that fact and I knew that they didn't have that in there. And like it didn't make sense to me, but I still chose it because I was so fixated on the fact that like your analysis is positive for blood, but no erythrocyte, you know?
Sure, sure. But remember, interstitial nephritis, I want you to remember that that disease process is more of an allergic disease process. Does it make sense?
Okay. Something
So
causes something else and like a drug.
yeah, like
Yeah.
for instance, like eosinophils are just white blood cells. That just means like inflammation. You actually don't really pee out too much blood. You just pee out white blood cells. It's not that you got infected. It's your body kind of being like, what the heck? Like I'm allergic to kind of NSAIDs or things like that. So if you take a biopsy of someone who has interstitial nephritis, it's just white blood cells, but there's not really. It's just inflammation of the kidney. Does it make sense?
Mm-hmm.
Okay, so you're not going to really pee out blood, right? And I'm talking on a symptom standpoint, so you can understand kind of the small little nuances instead of like memorizing buzzwords. Because sometimes they won't give you eosinophils, right? They might say, "Oh, you have this 40-year-old person that has chronic pain and uses tons of NSAIDs. His kidneys are a little bit inflamed, right? They took a biopsy and they saw a bunch of white blood cells. Okay, which of the following acute disorders most likely cause of this patient's kidney issues? You get what I'm saying? So they didn't say
Yeah.
eosinophils. They didn't say anything crazy. You're like, what the heck's going on? So you had to know that the risk factor that he takes a bunch of NSAIDs and now he has kidney issues. You get what I'm saying?
Perfect. Yeah.
Yeah. And then nephrotic syndrome, right? You don't pee out, you don't pee out blood, right? You pee out frothy, bubbly stuff that is protein, right?
Mm-hmm.
So minimal change is what comes up, and there's some other things too that can cause it also. And then tubular necrosis, just remember ATN. You get a lot of you don't create a lot of urine, right? Because your kidneys are sloughing off and they didn't have enough blood supply. There was an issue where there's lack of blood supply to the kidney, and so the kidney kind of is a little bit ischemic and sloughs off. But luckily for you, the kidney can replenish. Do you remember? I'm not sure if you kind of know this, but there's only a couple organs in our body that can quote unquote regenerate. The kidney is one of them. So
Mm-hmm.
the kidney, the liver, right,
Yeah.
can regenerate, and also skin, of course, and also your intestine mucosa. So,
Okay.
questions about that?
No, no, that makes sense to me. Especially because like this again was like a acute issue. Um, and yeah, like nothing else really. I mean, not to like just do process of elimination, but again, like that would make the most sense. Again, like
Yeah,
you're not making much urine because it's acute injury, and like they kind of blare that out, right? Like he got struck yesterday, and now like he has issues, and so
yeah.
it's like, what's okay,
Yeah, and just remember, right? And when I say acute, right, acute is always, relative, right? But in this setting, right, this is pretty acute, right? And your kidneys take a little bit, right? That it doesn't respond right away, right? But once your kidney gets it, kind of that hit of low oxygen, right? AKA gets a little bit ischemic, now it's kind of sloughing off, right? But it might take some time to show that. It might not show the first day. Of course, if you lose a bunch of blood, then it might show the first day, right? It just depends on your severity. So
mm-hmm. Makes sense.
but yeah, if you look on it in a clinic standpoint, it's the only one that can really be the answer. You get what I'm saying? If you look
Yes.
buzzwords, it becomes a little bit more difficult, right? Because you're like, okay,
Yeah,
which
they
one
don't
can
say
be
granular, muddy brown cast.
exactly. Exactly, right. So the only thing you got here is pees out blood, which can be a lot of this, right? Like almost all of these can pee out blood, right? Except D, right? So now you're like,
Yeah.
okay, so I have four things to choose from. What, you know what I mean? And so it becomes very difficult. So try to take it as a whole picture, you know? So,
Yeah.
all right, this one here.
So I looked at this one and immediately my eyes just drawn to the picture at first, I look at that to see if I can even just recognize it. But yeah, so I looked at this and I said, which of the following is the most likely cause of the anemia? And I read the answers. I looked at the things, a 65-year-old man with CLL, and he has sudden onset. So that was big to me, sudden onset fatigue and shortness
Okay.
of breath.
Yeah.
And then really, so he has anemia. I don't remember the hematocrit being, I think it's low for hematocrit. Um,
So do you know how to calculate hematocrit from hemoglobin and vice versa? That's a good formula to remember. It's pretty
the
easy.
only formula I know from like anything is like something 45 divided by 2 or something like that, or like something like I don't know, 45. I don't know. Actually, I don't know how to do
Yeah,
it.
yeah. So let me kind of draw here. So hemoglobin times 3 is equal to hematocrit. And then, of
Okay.
course, hematocrit divided by 3 is equal to hemoglobin. Okay. So if you're anemic, then your hematocrit is going to be low too. You get what I'm saying? They're
Yeah,
practically
it's
the same
directly
thing.
related.
Yeah, they're directly related, right? So of course you know that's low, right? So this patient's anemic for sure, right? Of course the highlighting's off, so I assume that you probably highlighted here, here, right
Yes.
here, right? Platelets, I think is relatively normal. I
That's
think it's one,
that's yeah, that's relatively normal.
yeah, and then reticulocyte is high, right? And of course, right, this is mostly, bilirubin is elevated and it's mostly indirect or unconjugated, right? So now they're asking, which of the following is the most likely anemia? So talk to me how you ended up getting C.
So I low key didn't know 100% just based off of this, and I was like, I feel like I should know this. um, but I looked at the answer, I looked at the picture, and I said, well, I know that. I mean, nothing was really popping out to me. I didn't think it was aplastic anemia just because, like, I think that basically everything would be low, and nothing in this, and that wasn't the case. I didn't get monoclonal gammopathy from this. And so I was looking at the answers. I remember just thinking like, okay, those look kind of spherical. That's
Okay.
literally what like I went off of as a bad reason, but I just said those look kind of spherical,
Sure,
and
sure,
I don't. Nothing else is like crazy popping out to me, is what I thought.
sure, sure. So key here is I would say that, I always talk about this, and of course, right, you probably during the time you didn't know was associated with CLL, right?
Hmm.
Okay, so that's one of the key things. When you get a heme question, right, you got to be thinking about associations, right? Associations are risk factors, right? So CLL is notorious for autoimmune hemolytic, right, syndrome, right? So
Yes.
even without this blood smear, I would pick B. You know what I mean? It doesn't change it, right? Because that's the
Yes, and
thing
I
that
looked
this,
at this afterwards and in the book because I remember looking at this like, is that even like a thing? Like, was it related to it? And I had like circled it, like I had circled that it was related to it in the
yeah.
book. But I was like, oh my gosh, I just forgot it.
Yeah,
And so
no, that's
yeah.
okay. Yeah, that's okay. As long as you I just want you to put yourself in that mindset, right? That you have to know the associations of your diseases because that's really what they're going to test you over, right? They're not going to
Mhm.
show you a blood smear and randomly be like, oh yeah, he has CLL, but also has hereditary spherocytosis. You get what I'm trying to say? It doesn't make
Yeah.
sense. Those are two separate unassociated diseases. Is it possible in life? Yeah, but what are the odds of that happening? Is super rare. So they're not going to test you like that, right? The way they're going to test you is if they test you on disease, they're really trying to get you, do you know the associations risk factors?
Hmm.
So yeah, that's going to be kind of my test taking strategy that I give you of this, right? Of course, someone can say, oh, you have to memorize that. It's autoimmune, hemolysis with CLL, right? Yeah, it is some kind of a memorization, but remember, I wouldn't say think of it as an association that you tack onto CLL. You know what I'm trying to say?
Yes. So like just from like now on, I need to know that like CLL, that's associated heavily with autoimmune hemolytic anemia.
Exactly. Exactly.
Okay.
And it kind of
Another
makes
thing too, I remember
yeah.
going through this question is that I like looked at it and I was like, you could also eliminate literally every other answer. in hereditary spherocytosis, you have literally no pallor in the middle of these blood cells. And so like just having pallor there at all would be wrong of that answer.
Yeah,
Microangiopathic hemolytic anemia, you'll see schistocytes, and there's no schistocytes here. It can be aplastic anemia because I think platelet count is normal. And then I didn't know really what monoclonal gammopathy was.
that's going to
But
be
that's
like
more of
your,
like MGUS or like multiple myeloma.
yeah, exactly. 100%.
So
Yep,
yeah, I was like, that doesn't make sense here. And so it could have just been this off of picking the wrong answer if you didn't know the
for sure.
association.
For sure, for sure. I mean, this is a tougher question for sure. The way I remember is for some reason I remember CLL. I think is it cold
Yeah,
or
cold and warm agglutinins or whatever.
yeah. So I can't remember if this is cold or is this warm? Let me see. Automaking circulating glycid IgG marker effects regardless of the site of the laboratory. Just remind yourself to look that up. I can't remember off the top of my head. I can't remember if CLL causes cold or warm agglutinins. I think it's IgG, if I'm not mistaken, which is warm. But yeah, just to add on to the association, so you know the mechanism. They might ask you.
Okay. Okay.
Yeah, yeah, predisposed to develop warm. Yeah, that's what it is. So IgG is what causes your autoimmune hemolysis. So just something to remember with it.
Okay.
Small little things, you know.
So this is the one that I actually, so I was done reviewing. I had finished my exam and or finished this first part, and I was reviewing stuff, and I was like, I think I can figure this one out pretty easy. But I'd gotten caught up on stuff that I other reviewed, and I went to this one, and it was just a mannitol. Like basically, what is the mechanism of mannitol?
Yeah.
And I knew the exact mechanism was to like it's an osmotic diuretic. It's going to draw salts out of the glomerulus into the serum, and so it would
Mhm.
go, the serum osmolality would go up. So it'd be A, B, or C. And I just didn't have time. I remember having like 20 seconds left on like, oh shoot, I haven't really picked an answer with this, and I know I can get it right. But I just picked C. And so this is one of my like silly ones that I knew the answer because if you have an increase in osmolality, I think ADH would be increased because your osmoreceptors are going to be increased. Um, or they'll like they'll like I guess start working because it detects an increase in serum osmolality. So you'll have an increase in water reabsorption to
Yeah.
stabilize the
Yeah,
blood.
exactly.
And
I
so,
think
yeah.
you kind of, explain that, super eloquently, right? Like you said, right? How your body works. If you're too concentrated, right? If you have too many solutes in your blood, your body's going to be like, I need free water to dilute that, right? So if you're urinating out all that free water, then your body's going to try to replenish it, right? So the ADH, which is antidiuretic hormone, which recollects, free water, right? So,
Yes, sir.
all right, work me through this one here.
This was another dumb one that I knew the answer to. I think it was asking basically which of the following mechanisms of action. So I got that he had ADHD from this, and I knew that you would give something called like methylphenidate, or I think that's the name of the drug, methylphenidate, or something along those lines. And I was like, I just don't remember what they do. And the moment I submitted the exam and looked at this question, I was like, oh, 100%. I knew that they inhibit the release of dopamine and norepinephrine from like the DAT and NAT channels or the DAT and NET channels.
Mm-hmm.
And so I knew that was the answer. I should have got that right.
Yeah, so Ritalin, methamphetamine, right? Or I mean, amphetamines, not methamphetamines, but those are all kind of you're talking about all these catecholamines that are released that helps you kind of focus. But yeah, this is just drug mechanism. So caffeine kind of mimics this a little bit, right? If you think about it, this is how I remember it, right? Just so if it helps you instead of just
Yeah.
memorizing it, you can kind of understand it or have a clinical correlation. People with ADHD, if you drink a lot of caffeine, it tends to kind of work a little bit like amphetamines, right? Because caffeine is a stimulant,
Oh
right?
yeah, and you would give stimulants to these people, correct?
Yeah, exactly, right. And so if you're talking about amphetamines, those are just stimulants, right?
Yes.
So dopamine, norepi, right? Those are all just catecholamines, which are stimulants, right? So people with ADHD, if you give them stimulants, they focus better. So there's some people with ADHD that do just fine with caffeine. If they take, 100 milligrams of caffeine, which is a cup of coffee, or sometimes 200 milligrams of caffeine, which is, like a monster or something, right? They feel like they're able to focus. And that's because it's a stimulant, right? It doesn't work as well as dopamine or epi, but it's a close adjunct. So
So
things you
also with the answer that I chose, GABA is more of like an inhibitory type of um what's it called? Like a hormone, correct? So it's going to be almost not very helpful in this situation at all
No.
because
So
yeah.
think of it like this, right? Exactly like you're saying, right? GABA, even though it's, enhancing GABA, but GABA is a neurotransmitter, is really works as an inhibitor, right? Or a downregulator, I would say, right? So for instance, the things that use GABA in general is like alcohol and then benzos, right? And if you've ever been drunk, right? If you drink, right, then you know that
Mhm.
you're gonna get really sleepy, right? Right. And that's not really what you want for people with ADHD, right? You want them stimulated to kind of narrow in their focus, right? So
Makes sense.
yeah. So the same, they always say the same feeling of, for instance, in surgery, we always give someone like Versed, which is a GABA receptor agonist, right, to help them relax. How they feel is almost like they're drunk, right? And
Okay.
the reason why is they work on very similar receptors, which is GABA, right? One I think is GABA A, the other one's GABA B or something like that, but very similar mechanisms of action. And so being drunk and being on a benzo are almost exactly the same feeling, even though I've never taken a benzo, but it makes sense mechanically. So
This one was making me mad. Which of the following labeled depolarization deep is associated with the smallest stroke volume? And I literally told myself it's B. Um, but I thought it was a trick, and that's honest to God is what I thought. I was like, this is can't be right. I didn't necessarily understand like premature ventricular contraction from this.
mm-hmm.
Um, and I guess I can ask you, like, when you see when is it just because there's no P wave, like no like discernible P wave that you have no like that's why you can be considered a premature ventricular contraction?
Um, shoot, man. Asking me the tough questions here. I can't read, PVCs. They're not one that I know the pattern for EKGs. So I couldn't really even tell you, to be honest. But all
Okay.
I know is this question, right? Is just the one that doesn't fit. You know what I'm trying to say?
Yeah,
Right.
and again, I saw that and I was like, this is obviously B. But I'm like, why would they make it so obvious that it's B? Is what I was
Sometimes
thinking.
that is what it is, Isaiah. You got to just kind of,
Yeah.
sometimes, I know it sounds funny, but the one that doesn't fit, even though sometimes it might seem extraordinarily obvious, it is the one that doesn't fit. You know what I'm trying to say?
Yeah.
So, I would say this, when you're taking this test, just think to yourself, these are not trick questions. You know what I mean? Like,
Yeah.
don't think that, oh, they're trying to trick me, etc. Right? Just think to yourself, okay, what's the odd one that doesn't fit? Let me pick it. And if it ends up being wrong, then kind of learn why it's wrong, right? But I mean, to be honest, I know I don't look enough. I don't look at EKGs enough, especially like I only know the big things, right? ST elevation, non-STEMIs,
Mhm.
a little bit of right deviation, right axis deviation, left deviation, right? Where the ST elevation is, these just WPW, right? Recognizing that, like I can recognize these things, but like PVCs, right? I don't see enough to know exactly the nuances of PVCs. I just know that B looks obviously no bueno compared to the rest.
Yeah. Yeah.
Yeah.
And so that made sense to me. But yeah,
All right.
this one made me upset. I thought I had this one down. I was very confident. So it said, which of the following is the most likely cause of the postpartum hemorrhage in this patient? And seeing the picture, I thought this was like, okay, something is just wrong here. And going off the question and the picture, I was already pretty set on abruptio placentae, just thinking like, okay, like a placental rupture is what I was thinking.
Okay.
And so I
So
read it,
yeah.
and it said like it was during 2 years ago, hysterectomy is required to control the bleeding. She's having like a massive hemorrhage after the vaginal delivery. And I was so set on it, I forgot the fact that like that's a third trimester bleeding issue, not a pregnancy issue, and not a like delivering the baby issue.
Yeah.
And so that was why I missed that question. I was so set on the fact that like, okay, this is like it just ruptured. And I was so set on that. And then I was like, oh yeah, hemorrhaging, good. Okay, I'm out of here. Like, next one.
Yeah, no, I got you. I understand the thought process. I think it's a good thought process, and in a sense that you recognize, you can see kind of the image, and you see a big hole in the uterus, which obviously is not normal, right?
Mhm.
But when you talk about, abrupto placento and things like that, right? Um, yeah, that's going to be like you said. That's going to be in kind of a different trimester. That's going to be while they're already pregnant, right? Um, so and you have different risk factors, right? You have different risk factors. It's usually trauma, smoking, cocaine use, right? Is
Yeah.
going to be placenta abrupta, right? So here, right, going back, I'm trying to push you to think about risk factors, risk factors, risk factors, right? So when you're learning about diagnoses, I want you to really be thinking, okay, in what clinical setting does this usually happen? You know what I'm trying to say?
Yeah.
Okay,
That's good.
because yeah, of course you're gonna be like, oh, okay, like there's an abruption, right, etc. I see this big hole in the uterus, but really, right, you have to kind of follow the clinical setting, right? She had a massive hemorrhage after vaginal delivery, so her chief complaint is actually massive hemorrhage after birth, which only that limits exactly kind of what can cause that, right?
You're
Very,
right.
very kind of narrow scope there of diagnoses that can be. And then also they give you even more risk factors if you're carefully looking, is that she already underwent a C-section, right?
Yep.
C-section,
Exactly.
another
Another
risk
risk
factor.
factor for placenta, creta, increta, per creta.
Exactly, right? So if you kind of piece this together, you're like, oh, they're really pushing placenta credit here, right? It's like, oh, she's bleeding after delivery, right? She had a C-section, right? And then, right, of course, she needed a hysterectomy to control the bleeding because she's a big hole in the uterus, which won't stop, right? And then, of course, they give you kind of the gross picture, right? Gross anatomy picture, which you have a big hole in the uterus here. And of course, right, this histology slide, which I can't see anything, right, because I can't read this, right, which is fine, because to be honest, do you need these two pictures to get your diagnosis?
No, you don't. As long as you understand there's a risk factor of like, okay, they just brought out the fact that she's bleeding during or right after delivery, and then she also had a C-section 2 years ago. And these are like risk factors for again the creta, in creta, per creta, and really nothing else here would like even line up with the diagnosis of delivery after, I mean, hemorrhage after delivery.
Yep.
Um, and so
Yep.
when
So
I
I'm
look
just trying
back at it, like, okay, yeah,
yeah, just trying to put it in perspective, right, as a clinical standpoint. And sometimes when you're reading these things, you're looking, like I said, you're looking kind of like so for something specific, right? And you're like, oh, I see this gross anatomy with the hole. It must be, abrupta placenta. Let's move on, right? But you got to put everything in perspective, because actually the overall picture gives you a better answer. You know what I'm trying to say?
yes, yes.
All right.
I was a 50-50 on this question, and I just didn't know exactly. But anyway, patient has most likely sustained an additional injury to which of the following during his initial accident. And so I believe he had like a seatbelt injury. I'm not sure if I remember this right. No, he was pinned against a loading dock by a truck moving in reverse. And the examination showed a descended bladder. Cystometography shows absence of micturition, and absent after the bladder fills to capacity, overflow of the urine occurs through a urethra, through the urethra a few drops at a time. And so at this point, I just didn't 100% know that if it was the hypogastric or pelvic nerves that controlled the internal urethral sphincter. And so I was like, I don't know 100%. I think it's hypogastric. I'm not sure. And so I was between those two, and I picked up hypogastric, and I was just incorrect about it.
Yeah, for sure. So easy ones to remember, because they will always test you on these, and you can fact check me. I always forget these every so now and then. But your pelvic splanchnic nerves, right? Those are your parasympathetics. Okay. They always ask you about that. And that's gonna your parasympathetics deals with urination and pooping and all that stuff, right? Because of the
Mhm.
smooth muscle, right? Hypogastric, if I'm not mistaken, that's just a sensory nerve. Okay. Um,
Oh, okay.
is it? Let's see. Hypogat. Oh, it also contains some sympathetic fibers, which I didn't know about. Right? They don't ask you too much about that, the hypogastric nerve, but they do ask you about your pudendal nerve quite a bit. So make sure you know your pudendal nerve. Trying to think of what else they ask you about in this area. Um,
They always ask that. They ask a lot about pudendal, especially with erections.
yeah, the
Um,
erections. That's the thing. I was trying to remember what a pudendal. I think it's the erection, and so um, They will ask that for the pudendal for the erection, and then the pelvic nerves will also always deal with the parasympathetic stuff. So those are your answers for almost all these questions. Those are just a test taking standpoint. They never ask
Mhm.
about hypogastric nerve, right? They never ask about these skeletal motor fibers. They never ask about external urinary sphincter. They ask about pelvic nerves and pudendal nerves. So make sure you know those like dead pat, because those are going to be your answers.
Okay, makes sense. Let me actually write some of this stuff down real quick. Sorry.
Yeah, for sure. Let me know when you're ready for the next one here.
Yeah. Okay. Okay, next one. I'm good for the next one.
All right, work me through this one here.
Okay, I misread this question. I was very frustrated. This was another one of my silly questions that I knew the answer. Anyway, so it said, which of the following is the most likely source of the increased serum CRP concentration in this patient? And it said, like, lady with lupus has increased CRP. I did not know this was asking, and this is like dumb, but I didn't know this was asking like where the source of it, like where it's made, where CRP is made, which I 100% knew was the liver. Or if it was asking where, like in this patient, would you see like increased like concentration of CRP, if that makes sense. Like why would this be increased? And so I chose kidney because I'm like, oh, obviously there's a lot of damage to the kidney in lupus. And I thought that was my reasoning for it. I'm like, I think this is what they're asking,
Gotcha.
even though
Gotcha.
like it said like where basically is it being made?
Gotcha. Gotcha. I guess the only thing is when you're dealing with kind of interpreting the question, Isaiah, I would say the best way is always to yourself, reword it and ask yourself, is this the most direct way they're asking this question? You get what I'm trying to say?
Oh yeah, like
Yeah.
so in this like where is it being made? Is it where what they're trying to say?
Yep, exactly right. And the reason why I say that is if you make too many jumps in logic, right? Kind of, I think what can help you with your kind of quote unquote silly mistakes is don't make too many jumps in logic. This test is way more straightforward than kind of what you're thinking. You know what I'm trying to say? Think to
Mhm.
yourself, what is the easiest way that they're asking this question? Oh, where is this created from? That's practically what they're asking, right?
Yeah.
Okay. And just as a rule of thumb for test taking, right? Most proteins are created by your liver, right? Albumin, right? Things like
All
that.
the factor 8, factor 9, like everything
Yep.
like that under
All these,
regulation.
all these enzymes, all these proteins mainly created in the liver, right? And of course, going back, kind of picking back to kind of what you're saying, right? CRP is a protein that you see in your blood. You get what I'm trying to say?
Yes. Yes.
So it's going to be
It's an
floating
inflammatory
around.
marker, right?
It's an inflammatory marker and it's non-specific, right? It's very sensitive. It just means like something's inflamed, but that can mean anything, right? But yeah, it's created in the liver. Right.
Oh, this is another one I was upset about. Anyway, um, I know I'm all like saying like, oh, anyway, which of the following is the most likely cause of these findings in this newborn? And so I read my answers and then I went down. I said newborn is delivered at 40 weeks gestation to a 20-year-old woman after an uncomplicated pregnancy. So it's a baby and physical examination shows male-like external genitalia with clitoral hypertrophy and labial fusion. The karyotype is 46XX, so it's a female. And even though this is like ambiguous genitalia in a female baby. And so the serum concentration of cortisol is decreased and serum concentration of 17-hydroxyprogesterone, androstenedione, and testosterone are increased. Which of the following is the most likely cause of these findings? And I was so fixated on the fact that this is like male external genitalia. And I had a question like this. I think it was rather in your question set or in UWorld. I don't remember how it was just in my back of my mind that I saw male external genitalia and I had a question that literally said like translocation of the SRY gene. And I was like, oh, it's this. And I just clicked that and I got through it. And I said, I think that's right because obviously, like, how else would you get male external genitalia? And I remember thinking to myself, like, okay, you have an increase of 17-hydroxyprogesterone, androstenedione, and testosterone. And I was like, that sounds like 21 beta hydroxylase deficiency.
Yeah.
And I just didn't think, I just said, no, I don't think that's it. And I moved on.
Gotcha. So So going back to your thought process here, right? So this is something that I want you to work on, Isaiah. So you see how like you're trying to answer this question with a factoid, correct? Like you're like, oh, I remember seeing this translocation causing external male genitalia, pick the answer, move forward, right?
Yeah.
But your answer didn't have much to do with the overall clinical picture, right?
No.
Because they told you that, they're telling you all this other stuff, right? Um, so they tell you that they're XX, and then they go into kind of your adrenal cortex, right? Your adrenal cortex enzymes, right? Meaning that your answer has to somewhat have that kind of answer. You get what I'm trying to say? Like you
Hmm.
have to have that included in your answer, or else like your answer has nothing to do with this serum concentration at all, right?
No, nothing.
So you have to pick an answer that addresses this. You know what I'm trying to say? So my thing
Yeah.
is I want you to work on that. Make sure to kind of look at your answer and it's like, does the case, right, support, does all of the case support my answer? If you have a sentence that's like, oh, this doesn't really go with it, then more than likely your answer is not right. You know what I'm trying to say?
Yeah. And I thought that too. And I was like, this doesn't make sense for this answer. But, and I told myself that, and I still went with the answer. And so, yeah. Yeah. So I need to look, you're saying I need to look more at this again, like stop looking at the factoids, which are not like, again, they're helpful when you know them and like, but look at this as a clinical picture, as a this is a new baby who's coming in here who has a male genitalia and these high levels of like all these different hormones and everything like that. So like which one of these answers that supports or which one of these is supported by the case is what you're saying.
Yep. Yeah,
And so
100%.
okay.
Yeah, so for instance, right, the only thing that supports your E is your male external genitalia, right? But B is a better answer because not only do they have clitoral megala, right? Because it says male-like external genitalia. So you have to also say that that's also like virilization or megaclitoral, right? And so,
Mhm.
and then she has high hormones, right? That support congenital adrenal hyperplasia. So.
Yeah.
All right. All right, Isaiah, let's take a 10-minute break here and we'll do some new questions together. But I think, going through that, the couple motifs from this test is one, focus on the clinical. If you focus on the clinical, you're going to reduce a lot of your silly mistakes. I don't think these questions are per se hard for you. I just think that you looked at it and you're like, oh, this factoid fits this answer, so I'm choosing it instead of thinking, oh, does this whole case is supported by my answer? So if you start thinking like that, you're going to minimize a lot of your silly mistakes.
Okay. That's a very okay, that's good.
Yeah,
Okay.
because I don't think that it's a knowledge thing, is what I'm trying to tell you, right? I think now you got to kind of step back and be like, hey, let's not rush or jump or assume. Just pick kind of the most like what does the case support, and also on top of that, what is the most obvious jump in logic? Don't jump 3, 4 jumps in logic to assume a lot of things. And the next thing you know, your answer choice, right? When we're reviewing, you're like, I don't know how I picked that, right? So you
Yeah.
want to you want to pick an answer choice that you can support, right? And talk about it. Even if you miss it, right? You have to be like, okay, so I chose this answer because, and if you can give me a good reason that's supported directly from the question, then your answer is probably pretty sound. If you're like, well, I remember this factoid, right, from somewhere else from another question, and I'm like, whoa, you're like really far removed from this question in particular. You know what I mean, Isaiah? So,
Yeah. Yeah. That makes sense. That makes sense.
all right, perfect.